All right, good afternoon. Welcome, everyone. We'll take just a minute or two to let everyone join, and then we'll get started. All right. Looks like the number joining has stabilized somewhat, so we will go ahead and get started. All right, so just a couple reminders about the about our webinar platform here. So if you need to use the Zoom chat function at all, we'll have a live Q&A at the end. You can ask any questions through the Q&A feature. The Zoom chat function would be more for any kinds of technical issues you might be having, or if you notice the slides aren't advancing, something like that. The slides will be available after the session, so we'll have a copy of the slides and the recording that'll be posted and available for download on Leapfrog's website. Let me just answer a question here in the chat for posterity. So for the Q&A portion of the question, you'll be able to do a couple different things. So one is you'll be able to use the raise hand feature that'll put you in the queue, and then it's when it's your turn to ask a question, we'll ask you to unmute yourself. You can go ahead and ask your question verbally. If you prefer to ask it by text, just by answering that question in the chat, that's no problem. We'll read them out and discuss them, or type an answer if that's easier. And then we'll have a transcript of the Q&A, that the questions at least that are written out, also available after the call. So before we get to our content here, just a couple quick introductions. I mean, I should say, I'm really thrilled to have you all join us today, because I think we've got a great session. We'll learn about two new and frankly compelling resources for hospitals of any kind that are looking to get started on the path to diagnostic excellence. And I think we might really have the two best possible presenters for this content here. So Dr. Hardeep Singh is going to walk us through these two resources. Hardeep wins an award just about every year for the quality and the impact of his work in diagnosis. So most recently this year, from the Society to Improve Diagnosis in Medicine, where he won the Mark L. Graber Award, and last year the Eisenberg Award from the National Quality Forum. We're really honored to have him on. And then, of course, Dr. Graber is literally the guy they named the award for, right? He is the founder of the Society to Improve Diagnosis in Medicine. His research, his work has affected really countless lives. And these two together, Dr. Graber and Dr. Singh, chaired our Leapfrog's advisory group on diagnosis, and were instrumental in helping us arrive at the recommended practices report and a few other things that you might have heard me talk about before, and then we'll give a little overview of today. So today, Hardeep will walk you through the resources, including like a little activity. And then, as I said, we'll have a little period to answer questions just at the end. But before we get started, I thought it might be helpful to just quickly review this project and set a little context for why we're talking about diagnosis. So beginning in 2021, so with some funding from the Gordon and Betty Moore Foundation, Leapfrog launched Recognizing Excellence in Diagnosis. So we convened an advisory group of really the preeminent researchers, clinicians, purchasers, patients, and their family caregivers who had both experience with, but also expertise in this area. So far, we've published a report describing 29 different options, call them recommended practices for hospitals looking to reduce diagnostic errors. And we also measured implementation of these practices by surveying about 95 hospitals across the country. So collecting some survey data from them, but then also doing a variety of follow-on interviews and so on, group sessions to get a little bit at the qualitative aspects of what they were doing. And this fall, we are translating all that research work into practice. We're going to add new questions to the 2024 hospital survey to assess the implementation of a few of these recommended practices. So now, as always, when we add new questions to the hospital survey, these won't be scored or publicly reported. So we won't report your responses. Instead, we will use your responses, but as a fact-finding opportunity to help us at Leapfrog better understand, how we should be setting, how we can set a fair standard in this area. But apart from your responses in and of themselves, you'll have many opportunities to give us feedback. So, that could be through your questions on the help desk, comments, through our public comment process, of course, our pilot feedback process. I mean, personally, I'm thinking of this really as the first of many steps before we move to formally scoring or more publicly reporting anything here. You'll see in the slide I've highlighted a couple of the resources we're going to talk about today, just because they're both featured prominently in our report, in our work, and they are closely linked to the concepts that we're hoping to assess with our new survey questions in 2024. And just a quick note from the Q&A I see. So Sophia asked, will you be adding this element to the actual Leapfrog survey? Yes. So we are adding new questions to the Leapfrog hospital survey. So again, not scored or publicly reported, but they will be in the survey instrument. We will collect responses on them. All right. Oh, and then if I'm not mistaken, I see a couple raised hands. I'm sorry, I'm not sure how long you've been out there, but maybe now would be a good opportunity to take those. So Regina Guevara, I think if you'd like to go ahead and ask a quick question, I think that'd be fine before we get started here.
I'm sorry, I raised it by mistake. I'm sorry about that.
No problem. All right. Very well. All right. So last slide then before I turn it over to Hardeep, just a few kinds of quick objectives for today as we, all situate ourselves at the start of this journey towards excellence in diagnosis in the hospital. So we want to learn about how organizations can move to become leaders in learning from diagnostic harms and striving towards diagnostic excellence, and how they can apply these two publicly available resources to start their journey. So with that, I will turn it over to Hardeep.
Thanks, Jean-Luc. I will try to share my screen. Okay. All right. Is this a presentation mode, Jean-Luc, or is this the normal mode?
This is normal.
This is okay. Sorry, this is, you want me to switch, right? To the
no. This is great.
This is good. Okay, awesome. Thank you so much, John, for the introduction and for inviting us to sort of discuss some of our work on diagnostic safety. So what I'm going to first try to do is to try to build a shared mental model for what we are doing. You know, I know Mark's talked to you about diagnostic error, but just to recap of what is it that we're trying to do through this project. We're essentially trying to prevent diagnostic harm, and how do we sort of characterize that? We've defined diagnostic errors as missed opportunities in diagnosis, either due to some kind of system factor or cognitive factor, or usually due to both, right? And the missed opportunity happens when, you know, when it leads to harm. It's a harm is either from a delayed treatment or a delayed test or a wrong treatment or a wrong test. We tend to focus our work mostly on, as you can see, areas A and B on this slide. Not all these missed opportunities or diagnostic errors lead to patient harm, but some do. And through this project, what we're trying to do is to sort of move the practice and policy related to doing something about these diagnostic errors forward. And that's the goal of this big project. So essentially, Mark probably showed you this earlier, but just to recap, there was a nice National Academy of Medicine report in 2015 that talked about improving diagnosis in healthcare. This is a model that they've sort of created based on some of our work, where essentially you can see the diagnosis as a process. Of course, it's not very linear in real world practice. You know, after a patient engages with the healthcare system, of course, there's information gathering. But, you know, in addition to history, physical referrals, all of this sort of happens in a non-linear fashion often. And when we talk about diagnosis related things, we generally tend to think about not just the physician or the clinician related issues, such as cognition, decision making, but we also need to be thinking about system related issues that affect that, right? So if I'm having a busy you know, time in clinic, or my electronic health record is not very usable, all of those things affect the way we do our decision making. So we need to think about all of those things as we think about diagnosis. So a couple of themes from our findings from research. What we've seen in our work is common conditions are getting missed, relatively common conditions. So it's not just the diagnostic dilemmas or the zebras, which we call in diagnosis, that get missed. What we also see is a lot of these diagnostic errors and missed opportunities are from not eliciting or acting upon key clinical findings, often related to physical exam and history taking. So we get this very often in our work. And of course, with electronic health records, we also see a lot of information that has been overlooked in the electronic medical record. So before I talk about some of these more sort of recent resources that we built to sort of try to tackle some of these issues, I want to just try to define diagnostic excellence for all of us. And this is sort of comes from a body of research that we've done. Diagnostic excellence is not just about making a correct and timely diagnosis, but it is also involving 4 other characteristics. And those 4 characteristics are sort of highlighted on the right side of the slide. You also need to make the correct and timely diagnosis using the fewest resources. So the best diagnostician is the one that can make the correct and timely diagnosis using fewest resources. So if you test everybody, you might find something, but that's not the point here. You also need to maximize patient experience. We need to manage and communicate uncertainty to patients, which often comes with diagnosis, which is what makes it kind of harder to tackle than other types of patient safety issues. And then we need to tolerate watchful waiting when unfocused treatment may be harmful to the patient. So what we've done in our work is to try to take a very systems-based perspective on diagnosis. So we think that this is not something that is only happening in a clinician or a physician's brain, that they just think and come up with a diagnosis like Dr. House, but this is more of a systems-based process. So we call it sort of the socio-technical approach, or a socio-technical framework that we use to understand the diagnostic process. And that you can see that it has 8 dimensions, and those 8 dimensions, some of those are technical dimensions. So if your computer or your electronic health record is broken or is not very usable, well, that's not going to help you make a diagnosis correctly, right? So we have to think about personnel issues, we have to think about policy, communication, and most important, people forget external rules and regulations really affect the way we practice medicine. And things that CMS says or Joint Commission, National Quality Forum, Leapfrog, all of these are entities that affect the way we practice because it influences the entire socio-technical system. So this is a framework. As a researcher, we develop a lot of frameworks. One of these is important for this project, and that's about measurement, and it's called the SafetyX framework. What it essentially says is diagnosis is involving 5 different processes, and we need to tackle all 5 processes in any project related to promoting diagnostic excellence. And those 5 processes include, the doctor-patient encounter or the clinician-patient encounter, but it often also includes testing, which is the orange bucket, testing performance and interpretation, also includes referrals and consultations, includes follow-up and tracking as well, right? So if somebody has an abnormal test result, which is an abnormal X-ray or incidental finding, that needs to be followed up as well. Even though you may have had it in the emergency room as an incidental, it still needs follow-up. And then the patient is at the center of the diagnostic process. And these 5 process dimensions have been very useful to think about in some of our work. And what we advocate is, and one of the resources that I'm going to talk to you about is essentially based on this model. We need to create some types of measurement mechanisms for diagnostic errors to figure out what is going on in a health system, what kinds of safety events are happening, because that promotes organizational learning, it promotes collective mindfulness, and you can use all of that information as a feedback system for improvement and create safer diagnosis and improve patient outcomes. So the context of this type of a program that we're sort of presenting and discussing within sort of this Leapfrog purview is one of the ways that we move the practice of this issue forward is by monitoring. So the Improving Diagnosis report that I mentioned earlier in 2015 said that healthcare organizations must have some programs in place to monitor the diagnostic process so they can essentially learn from it. And you can monitor the diagnostic process in several ways. You can, of course, look for errors, but you can also look for good catches. You can look for pockets of excellence. You can monitor the diagnostic process in every way. So we created based on some of our thinking, we created this model called the lead organization model, which is sort of the learning and exploration of diagnostic excellence. And we said that if an organization was to achieve diagnostic excellence, so this is not an individual, this is not like at an individual clinician level. If an organization or a hospital or a health system was to become or explore diagnostic excellence as a concept, they have to do 5 things. The first thing they have to do is to create some type of a virtual hub to coordinate activities related to diagnostic excellence. So you need to have some focus of activity. So people who think about diagnosis, promote diagnostic excellence, learn from diagnostic safety event, all of that. And then you have to have 4 additional actions. You need to have measurement for improvement and learning. So by that, we mean, we're not thinking quality measures. We're not thinking these metrics that people are sort of exposed to. We think of measurement as a way to learn, the way to improve. So you gather sort of across your health system, what types of diagnostic safety events are happening, and then you learn from it. And that's what we mean by measurement for diagnostic excellence. And that's the resource that I'm going to talk to you about in this talk. Second is generating and translating new research evidence. So this is actually a new field. We're still learning a lot about it. So organizations need to work with sort of researchers such as I and others and Mark who are in the field of trying to promote diagnostic excellence so we can get you the tools and resources that you need for making things happen. We need to engage clinicians. So you can see that as a next bucket of activities. And then lastly, we need to build an accountable culture that engages and learns from patients. And I'll give examples of each of these. So the first thing is we can measure by our electronic health record system. So we've been able to leverage large amounts of electronic health record data where we build algorithms that can identify patients who are either at risk of getting a diagnostic error or may have had a diagnostic error. And so I'll give you an example. So if you have a patient who was admitted to the hospital, who was a healthy person, no medical problems, but 2-3 days later, they got escalated to the ICU after a rapid response. We looked at that. We looked at that as an electronic trigger. So we looked at like 90,000 patients, and we identified just about 90 or so who had had this event. And then we looked at these patients and found about half of them had some problem or the other. Some of them were later diagnostic problems, and some were other kinds of problems. Another kind of trigger is a visit, let's say to the emergency room or primary care, where somebody comes in, but then they unexpectedly get admitted to the hospital after being discharged for the first time. So we look at the visit to see, did something else happen the first time when the patients presented, or something missed, so we can learn from that. And you would say, well, what do you do after this? So you identify some of these patients who may have had some events of some kind, safety events. What do you do to learn from them? Well, what we do next is we review their medical record using medical record review instruments, such as this one, Revised SaferDX instrument, which can be used to evaluate the medical record for missed opportunities related to diagnosis. And the reason I'm building this up is a lot of these materials are covered in the resources that I'm going to tell you about. MeasureDX is the one that John-Luc mentioned. All right, so when we look at the medical record, we not only identify the missed opportunity, whether it exists or not, but we also figure out, can we do something different? Should we have done something different about it? Or what were the contributing factors that we can actually do something about? And so it's a very actionable medical record review. All right, the next way to do some type of measurement to understand what kind of safety events you're having is to engage your clinicians. So number one was EHR data, but the second is engaging clinicians. This is really important because clinicians often know what kinds of diagnostic errors are happening, or which colleague made made an error, or something that they had learned about. So this is an important source of data, which is very underutilized. Most of you probably are in health systems where physicians report very little of all your reported data, and that's quite normal. Less than 5% or so comes from physicians. But they're a good source of information. And so there was this very cool project that was done in Cincinnati Children's Hospital where a fellow went around and asked clinicians or their faculty as a fellowship project, what kinds of learning opportunities are you finding related to diagnosis? She didn't ask them about diagnostic errors. She just asked them about, tell me, do you have a learning opportunity related to diagnosis? And in 6 months, she got about almost 100 or so cases of what seemed to be diagnostic errors. And such an effort has been done in the emergency department as well. What you really need is a champion, a physician champion who can sort of lead. You need some protected time from the institution. You need to have leadership engagement and support to do such projects. We also wanted to sort of throw this out there. One of the major ways of learning and improvement, at least at the clinician level, is seeking feedback on diagnostic decisions. So we published a paper in BMJ last year about how clinicians can advance diagnostic excellence at an individual level. And one of the ways they can do that is seeking feedback on diagnostic decisions of their own. And we built a resource, and I'm not going to go into too much detail about this. It's freely available on AHRQ website, and you can sort of just take a picture or look at the slides. It's called Calibrate DX. It's a resource to improve diagnostic decisions where clinicians can look at their own cases. So we walk through this entire process of having clinicians look at their own cases so they can learn from them and they can improve their skills. And there's a way to select which cases you look at. You can also engage patients. Patients give a very different perspective on diagnostic errors. So we talk to patients who are misdiagnosed, and one of the most common things they tell us is the reason I was misdiagnosed is because the doctor did not listen to me. And I kept telling the patient, I kept telling the doctor about the same issue, and the doctor didn't listen to me. So it's a common problem that we've seen. So we've learned from patient complaints, we've learned from narratives from patients. We've even tried to use open notes to try to get patients to submit something around their notes that they might find diagnostic concerns with. And so there's all kinds of ways we could learn from patients on what kinds of concerns around diagnosis they have. Okay, so now let's move on to the resources. With this background, you'll now figure out why we developed these resources. So if you want to build a learning health system for diagnosis, so if you want to move towards what we call LEAD, learning and exploration of diagnostic excellence, you need to sort of figure out, okay, we want to create an initiative to learn and improve, right? This is all about learning and improvement. The first thing we have to do is to conduct a prospective risk assessment to figure out where do we stand? What are our current practices? How well are we doing now? Then you can gather and analyze data for learning opportunities, sort of which is the next point in that circle. The reason you do that is because then you can figure out where your measurements are, what your measurements are telling you, what kinds of high-risk areas you have, and then you can take actions to change practice. And then, of course, you have to sustain that initiative. And that's a way to involve everybody, right? Patients, health systems, policy and practice folks, as well as clinicians. Now, how do you conduct a prospective risk assessment? So I'm going to focus on the risk assessment tool, which is SAFER-DX checklist, which I'm going to walk through next. And then we'll come to Measure-DX, which is the tool to gather and analyze data for learning opportunities. So the SAFER-DX checklist was developed in collaboration with IHI. It is a tool that thankfully has only 10 practices. One is a front page. It has 4 pages. One is a face page, which you are looking at now. The second is an implementation guidance document, which is 1 page. And then the practices are over 2 pages. So it's basically a short, easily implementable tool that is also freely available. Here's what it kind of looks like in general, but what I'm going to do is I'm going to do a walkthrough so you can see how well you're doing. So just quickly going to tell you, if you want to use this checklist, what you do. You identify a senior leader, because otherwise nothing will get done. You put a team together to get stuff done, to do the assessment, complete the checklist, but most importantly, you need to have an action plan. So what did you learn from the checklist? Do you want to do some items that you were not doing earlier? And then you need to follow up and make sure that those actions you wanted to implement based on your assessment are being done. We have 3 implementation status choices. Full, that means your organization really does this practice well. It's well known to you, and you have this practice done reliably at your organization. The partial is, well, some people are doing it, some are not doing it, it's inconsistent. And not implemented, that means that practice does not happen at your organization, right? So these are the 3 choices. And now what I want you to do is I'm going to walk you through these 10 over the next few minutes. And I want you to keep a running tally of how many times do you select full, because I'm going to ask you at the end, how many full do you have out of 10? And then we'll do a little bit of a poll that hopefully John-Luc can help us with to make sure that can happen. Okay, so this is the first practice. Your organizational leadership has built a board-to-bedside accountability framework that includes structure, capacity, transparency, time, and resources, specifically to measure improved diagnostic safety. Just remember, you're not doing this about patient safety in general. You're doing this about diagnostic safety. Yes, there's overlap, but there's also some differences. Diagnostic safety has to be a part of your action plan. So that's the first one. Just remember, think about it, partial, full, or none. Second, your healthcare organization promotes a just culture and creates a psychologically safe environment that encourages providers and staff to share opportunities to improve diagnostic safety without fear of retribution. How many of you think this is fully implemented at your organization? Keep those answers recorded, so when we ask you at the end, you'll have them ready. Third one, your healthcare organization has created feedback loops to let people know about the outcomes of their patient's diagnosis. So if I'm a clinician at your organization, whether I work in the ED or work in the hospital, I have ways of finding out feedback on the patients that I'm seeing. What's happening to them clinically? What was their subsequent diagnosis? Oftentimes, clinicians don't find out about what happens to their patients. Does your organization have a feedback mechanism to give this data to clinicians so they can figure out what's happening to their patients? Fourth, your healthcare organization includes multidisciplinary perspectives to address and address contributory factors in analyzing events related to diagnostic safety. Specifically, you got to think about, do you have human factors, informatics, IT system design, and people who understand cognition on some of these events related to diagnosis? Are you able to perform an analysis that includes a multidisciplinary approach? Can your organization do that? Okay, next. Next one is your healthcare organization actively seeks patients and family feedback to identify and understand safety concerns and addresses those concerns by co-designing solutions. So I'll give you examples of that earlier, patient complaints, things like that. 6, your healthcare organization encourages patients to review their health records, of course, with 21st Century Cures Act, that's very important. And they have mechanisms in place to help patients understand, interpret, and act on diagnostic information. And in the checklist, you will notice that we have also given some implementation examples. So when you look at the actual checklist, you will see much more than the practice to explain what we mean. Okay, the next one is your healthcare organization prioritizes equity in diagnostic safety efforts by segmenting data to understand root causes and implementing strategies to address and narrow equity gaps. Okay. Number 8, your healthcare organization has in place standardized systems and processes to encourage direct collaborative interactions between different clinical teams, such as the clinician and the laboratory, the clinician and the radiologist, the hospitalist and the pathologist, in cases that pose diagnostic challenges. How often do you do that? And do you do that at all? 9, your healthcare organization has in place standardized systems and processes to ensure reliable communication of diagnostic information between care providers and patients during handoffs and transitions throughout the diagnostic journey. So as you know, handoffs are a critical point in safety risks. And then lastly, your healthcare organization has in place standardized systems and processes to close the loop and on communication and follow-up of abnormal test results and referrals. So we know that about 8% of test results often get lost to follow-up, and patients have delays in their care because of that. So now, let's go and count the number of practices that are fully implemented at your site. And John Luke, do you have a way to do a poll now? Okay, perfect. All right, John Luke, are we getting some answers? Because I can't really see on my screen.
Oh, yeah, we've got, let's see, just about 100 folks have written in. Okay. Although they're still coming in, so.
Yeah, as long as you can display them so everybody can see it. I can't see anything on my end, at least.
Well, let's go ahead and give it, let's say 30 more seconds, and then I'll end the poll, and I think that should show the results. All right.
Okay. So as you can see, almost 57% are beginning. 39% of you said you're making progress. And 4%, 5 out of 114 responses, you were exemplar. We really would like to hear from you. So please email me after this. And we want to know what you're doing. And let lead folks know who you are as well. Thank you. This is great. I will close this. Okay. Okay, let's go to the next resource. It's called MeasureDX. It's also freely available. This is available from the AHRQ website. As I mentioned, it's a resource that can help an organization identify these diagnostic safety events and learn from them. And what we do in MeasureDX is we lay out pretty much the framework that I described earlier. You sort of prepare for measurements. You have to obviously get leadership buy-in. You build a team. Psychological safety is really important. And then we have a little bit of a self-assessment. This self-assessment is different from the SaferDX self-assessment, although surely you can do both. In fact, you should do both. We consider SaferDX initial because it's more like a prospective look, and then you start analyzing your events, and hopefully you get better, so then you can maybe do another SaferDX assessment later. So you do the self-assessment. Then the third is you implement measurement strategies, and there are 4 measurement strategies. I'm going to show you those in a minute. None of them will be a surprise to you. And then you review and analyze cases. We walk through this process very sort of systematically, so it's sort of very clear to you, and we use a lot of case examples in MeasureDX. Of course, it's not a light resource. It's got several pages, but it's a resource that can really help you with your activities at your organization in each of these 4 areas. Now, what are those measurement strategies that we recommend? They are built directly on the examples I showed you earlier. One is you can use your own quality and safety data. So you can look for signals in the safety data that you already have. I mean, all hospitals use safety data, right? You can just look for signals of diagnosis within your safety data. Or you can build a system that can solicit reports directly from clinicians. So I give examples from Cincinnati Children's where they directly got clinicians to report diagnostic learning opportunities. And actually for that project, they built a system which was independent of the reporting system. It was much easier to use. It was just a few lines. Here's a patient, here's a medical record number. Now, I must say, all of these examples are very well covered in the resource. So you don't have to sort of, look very far, and you'll be able to get through all that information. You'll find all that information in MeasureDX. The third is you can leverage patient-reported data. Again, we use case examples. Can you do surveys? Oftentimes, patients are writing things in surveys that is narrative text. And you might not see it very easily unless you read the text. Oh, that's when you realize, oh my God, the patient really had a problem with diagnosis, or they had a safety event. So some health systems are analyzing the narrative data through patient surveys because patients have written in comments that need to be analyzed. I gave the example of patient complaints as well. And then lastly, I used the example of triggers earlier. You can use your electronic health record data to enhance the chart reviews that you're doing. So just identify the few high-risk patients that you want to look at. What the concept of electronic triggers do is they essentially help find needles in the haystack by making the haystack smaller and using magnet to pull out the needles. Essentially means instead of looking at 1,000 medical records, you'll only look at 50 or 25 because the electronic health record trigger tells you which ones to look at. So that's why we call it enhanced chart review. So you don't have to spend so much time in doing chart review. And then finally, once you get all that information, you identify the case to review, you figure out whether there's a missed opportunity. I showed you the revised SaferDX instrument earlier. It's a really helpful tool to kind of get your hands around, was it a missed opportunity or not? And then you can analyze that data for contributory factors, looking at other taxonomies, and figure out where you can improve. Now, What happens over time is, let's say you analyze 50 or 100 cases over a year or two, you really start to get a sense of where your vulnerabilities and your weaknesses are. So several health systems, they found information. Oh, looks like we're losing, test results from, let's say, the emergency room because people are not following up on those incidental findings. And so you can get patterns through aggregated data as sort of a next step, and you look at these trends. So I'm going to finish off here on the slide and open up for questions. But essentially, we made a lot of progress in the last few years, even though this problem is quite complex and multidisciplinary, multifaceted. We've got strategies for clinicians now, and I gave you several examples, and we've got actionable steps at the organizational level, what you can do to improve patient safety related to diagnosis. I want to thank all my research agencies. My information is here, and I'll be happy to turn it back to John Luke.
All right, outstanding. Thanks, Hardeep.
Let me stop share. All right, see you back to you.
Absolutely. All right. Okay, so just a quick recap. Well, thanks very much to Hardeep for that excellent presentation. I think that was really instructive, and hopefully will give you all something to think about in terms of your next steps on improving diagnosis. And just to restate what I said at the beginning, in case anyone missed it, but this fall we are adding new questions to the hospital survey to assess progress on the path to diagnostic excellence. So these questions, again, won't be scored or publicly reported, but they will be in the 2024 hospital survey. These will be optional for fact finding, just to help us better understand your progress in this area and where it might make sense to set a reasonable standard to work against. So with that, I think we have plenty of time to take any questions you might have, either for Hardeep or for Dr. Graber, who's on the call, or for myself and the Leapfrog side of things. And again, you can use the Q&A function. You can feel free to raise your hand and speak your question out loud. We'll take any minute else.
John Luke, before I just want to clarify, I put it in the text to make sure the Safer DX checklist is diagnosis specific and has 10 items. The ONC Safer guides, there's a couple of you, I think, sort of were asking in the chat, are different, even though, as I said, our team developed both, but the ONC Safer guides are electronic health record related sort of checklists. They are very extensive. They have 140 items. They are required by CMS. 2 of those are relevant to diagnosis. One of them is communication of test results, and the other one is communication in general between clinicians. But what I mentioned, Safer DX checklist, it's a different IHI, done in collaboration with IHI. It's a different item than the ONC Safer guides, just to kind of make it clear.
Okay, thanks, Hardeep. All right, maybe we'll start the first question in the chat from Jessica. I'd love to hear more about how to use the EHR to search for high-risk diagnostic patients for chart review. And Hardeep, maybe.
Yeah, I can do that. So essentially what we do is, and I'll type in a couple of papers that can help people do this. And in fact, we actually have an AHRQ funded center now to try to promote this work and take this more out of research into clinical practice. What we do is we work with the people who do data analysis related to the EHR at the organizational level. And we build algorithms that can identify just a few patients that can be reviewed based on certain patterns of visits. So the one like we're testing, I'll just give you an example. Somebody comes to the ED and they were sent out with, treat and release visit. And 4 days later, they came back to the ED and now they are admitted with appendicitis. But they were initially seen with abdominal pain. and now they're coming back with appendicitis 4 days later. So through the electronic health record query, what we would do is to identify this patient and then review the medical record to see, oh, was there something missed on the first visit, which was suggestive of appendicitis? And that's how we the query helps us narrow down the patient groups to look at, so that we don't have to look at every single ED visit or every single hospitalization, but we narrow down to just a few that we want to look at. So this is the work that we're doing with some health systems, Advocate Aurora and Harris Health in Houston. We're trying to move these triggers out from research environments into clinical practice. Of course, it needs data analyst time. It needs people who can review charts. But if your organization is willing, feel free to reach out. We definitely would like to talk to people on how some of these algorithms can be exported to other health systems as well.
Excellent. Thanks, Hardeep. So we do have one question about which section we're going to add these diagnosis questions to. So we'll have more information about the exact questions we're going to ask on the survey and how they'll fit into the survey overall on later on in November, when we release that as part of the full package of proposed changes that we put out every year to the hospital survey. So you'll have a chance to answer, to review that information. Then we'll have that comment period for a few weeks, so you can take some time to figure out exactly how you feel about those and let us know. And then obviously we'll have a lot of opportunity for back and forth there if you want to contact the help desk. So all this to say, there's in terms of the information on the questions on the survey itself, there's more to come there, and we'll have an opportunity to review those in detail later on. The next question maybe that we can take is there evidence that these interventions decrease diagnostic errors?
So are you talking about one specific intervention? I know it's from an anonymous attendee, so I don't know whether you want to make yourself known, but which intervention are you talking about?
If I see a follow through, it'll come in.
Yeah, and I can mention in terms of the two resources that I presented, the Safer DX, it's basically a self-assessment. So we just released it last year, and we're getting organizations to do a self-assessment to see where they stand. And all of these items that we put, the 10 items, are all things that have been known in the literature to improve safety and diagnosis. And I'm actually, somebody asked for the URL for Safer DX checklist. I'm going to put it in there. And actually, I'll put one that you can go directly in without having to go to IHI website. The Measure DX part, we just finished an evaluation with 11 healthcare organizations. And what we learned was, of course, you need sort of that organizational infrastructure to get things done. But people started finding things that they didn't find before with the use of these tools. And measurement, we think, is a first step to improvement. And it's not just easy to say, oh, did the error go down, or did any error go up and down easily? But you can really figure out if this is a good learning resource for your institution.
And actually, I'm pretty interested in one of the questions here. I mean, because I know we were all at the CITM conference recently, and there was a lot of talk of AI. I mean, can either Hardeep or Mark, you want to just speak quickly to maybe your sort of general sense about the role that AI might play in some of this, in a forward-thinking kind of sense?
I can start, and then maybe Mark can go in as well. AI can do pretty well as far as pathology, radiology, dermatology, ophthalmology. Everywhere there's a visual image, AI can do reasonably well. In fact, there's already sort of evidence that AI can do well. The recent enthusiasm about AI is, generative AI and ChatGPT, where AI has been able to sort of, match sort of doctors' competence on taking a test. So I'm going to put in, again, another paper that we just published in JAMA about clinical diagnosis and AI. So this is not visual diagnosis that AI is really good at, but clinical diagnosis. But there's several things that are still, I would say, more hype than real advancement, at least right now. Because, if you can't get the history and physical from the patient, I don't think you can enter that in that ChatGPT. ChatGPT is not going to take a history and physical yet. So you still have to talk to the patient to get the data and put it into some kind of an AI solution such as ChatGPT. There's a lot of uncertainty involved in diagnosis, and I think ChatGPT sort of doesn't do very well unless it's black and white. And so I think there's a lot of potential going forward about use of AI, but right now, I think the focus should be on some of the non-AI things that we all sort of have been sort of working on.
Jean-Luc, this is Mark. I'd like to weigh in on that one too, if I may.
Yeah, please. Yeah.
So the most common diagnostic error I've seen in my studies are situations where the clinician is trying to figure out what's going on and they come up with a possible diagnosis and it explains all the pieces of the puzzle. So that's the diagnosis they go with. And that usually works pretty well, but it's not entirely reliable. And what we found is that if clinicians took the time to stop and think or use decision support resources, they might come up with a better answer. So there are decision support tools out there that have been available for many years. And we're talking about Isabel or Visual DX or DXplain, some of these systems that are in use in many hospitals already. And these are a huge help for differential diagnosis. Hardeep has a study where he looked at patients with diagnostic error. 80% of the time, there was no differential diagnosis in the chart. So that's where these decision support tools come in handy. They help you think of other possibilities and what else it might be. We say that's the universal antidote for diagnostic error, just to ask, what else could this be?
Awesome. Thank you. Thank you, Mark. Just a quick question here for Philippe. So Doug asks, when do you plan to score or publicly report the outcomes of these self-assessment tools in future surveys or letter grades, or do you? So first, just a quick point of clarification here. So the self-assessment tool that Hardeep presented is different than the questions that we'll be asking on the hospital survey. I mean, obviously the concepts are very closely related, but the exact questions that we're going to ask, and some of the specifications there, the terms, the FAQs that we provide you, we're going to create a different body of information that we'll ask you all to respond to. And we'll have our usual attendant data verification processes with that. So it'll work a little bit differently than the self-assessment. In terms of scoring and publicly reporting, so we won't score and publicly report anything in 2024. And we would hope at some point to score and publicly report that information, that data submitted through the survey. And where it makes sense, where it's closely related to the concept of patient safety, even use it in the safety grade. That said, we want to be really careful, since this is quite a new initiative, a new area for a lot of hospitals. I think the poll kind of speaks for itself, right? Most places are early on in their journey here. We want to, it may not be possible to move to a fair scoring regimen right away. And different sections on the Leapfrog Hospital Survey historically, we might take a year or two or more of having questions, of gradually refining optional questions that aren't scored and publicly reported before we move to that scoring and public reporting. So we don't have a definite timetable at this point, other than to say in 2024 it's not scored or publicly reported, and our goal is at some point to score and publicly report the data that's submitted here.
So John-Luc, I think both Tom and Heidi have raised very good questions on, like, what's a diagnostic error? Like, when do you consider a diagnostic error? So I'm gonna just put into the chat a paper, which is actually on the Device Safety Extension, which you might find useful anyway, which has in recommendation 1, what we think has been sort of the best, most useful shared understanding of what we think is diagnostic error. Heidi and sort of Tom, I think, also is trying to do that. Both raise this point that sometimes diagnosis change and evolves with time, right? So what happens then? Like, what if was my diagnosis an error if it just evolves? So we don't consider necessarily if the diagnosis evolves an error unless something was missed earlier. So take a look at this paper. I just put in the chat, and basically we say, there's sort of 3 criteria. One is case analysis reveals evidence of a missed opportunity to make a correct and timely diagnosis. The missed opportunity is framed within the context of an evolving diagnostic process, which is sort of Heidi's point. And the opportunity could be missed by the clinician, care team, system, or the patient. So we kind of take a very broad perspective, but we definitely try to exclude some of the areas where it just would not have been possible for somebody to make a diagnosis because the situation is changing or whatever it might be.
Awesome, thank you, Hardeep. Diddy actually has a great question. We got 2 minutes left in the session, and I wonder if any of those few folks that said that they were either quite well along in their journey. I think there were a few of those, or the many who said they were making some progress. If anyone wants to unmute and just give us a couple minutes on what you've been working on in terms of misdiagnosis at your hospital, we'd be really interested. But of course, as already said, if it's we'd certainly like to hear from you offline as well in a follow-up email. But if anyone's interested, please go ahead and let us know. I'm not seeing any volunteers, which maybe is not too surprising. It can take a little while to gather your thoughts, but please do feel free to reach out after the fact. I think we have time for one more question, maybe.
There's one from Tom. I think just sort of clarification. It's not like we exclude like any particular instances. So in an ED for patient use without being seen. So that's an opportunity. The patient left. Okay, can't really do anything. You might want to evaluate, why did the patient leave? And so, it's not like a hard and fast rule on what we include. Essentially, if there's an opportunity for improvement, that's what you should include. So, maybe the wait time was way too much, 4 hours, and the patient left to go to another ED. And so that could be another, what you glean from that instance. But there's no hard and fast rule on what we excluding. It's mostly your internal assessment. I think the paper I sent will also be helpful.
Great. Well, thank you so much, Hardeep. Okay, so I do see a few different unanswered questions in the chat, but I think what might be best is if you want to go ahead and write into the Leapfrog help desk. We'll take our time to give you a nice complete answer. Alternatively, you can just reach out to me directly. I'll be able to answer you too, but we do want to make sure we respect everyone's time here. So I appreciate Mark and Hardeep for taking the time to walk us through these resources. I'm really grateful that everyone took the time to join us this afternoon to learn a little bit about these resources. I hope you'll take the time to check them out. And of course, please do be on the lookout for more information about this section in late November. And actually, right around late November, to celebrate, we'll have our third and final webinar in this series of an introduction to diagnosis. Divi, who's actually been so helpful participating in the chat a couple of times here already today, is going to tell us a little bit about Geisinger's approach and some of the successful things they've done there. And then Jill Dykstra Nikinen, a quality officer at the Arnold Palmer Hospital for Children with Orlando Health. She'll do it about the same, right? She'll tell us a little bit about how her organization has approached misdiagnosis. And so same thing there. We'll have some presentations, but we'll have a nice opportunity for questions and answers. And we're hoping that this will be a really helpful session to help take you all. Yeah, I hope you can all see sort of the idea with the series there, right? So that first series with Mark, introducing everyone to some of those concepts there and telling you about Leapfrog's project. Today, looking at some of the different resources that can help you get started. And then finally, hearing directly from some folks who are doing the work and who, hopefully you'll all benefit from learning from them just as much as I have. So with that, we will leave it there. Thank you all very much for joining us this afternoon.
Thank you.